Hello, you are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, I want to take you through paralysis of one muscle and of course an injury to a nerve, which of course can be tested, clinically. Okay, so that we can see the manifestation. Okay, and so without wasting my time, let's set the ball rolling. My friends, today we talk about a nerve, an important nerve, and my friends, this nerve is called the long thoracic nerve. Now bear in mind that the long thoracic nerve, yes, can also be referred to as the external respiratory nerve of Bell, or simply the nerve of Bell. My friends, we are calling it the long thoracic nerve for the reason that it is very long. Yes, it is of course about 22 to of course 24 centimeters long. Yes, and of course it runs on the superficial aspect of what we call the lateral aspect of the thoracic wall. Okay, and for this reason it makes it highly susceptible to of course injuries. Now, to talk about this long thoracic nerve by way of origin, my friends, it originates directly from, of course, the root of the brachial plexus. And my friends, I'm talking about the C5 root, the C6 root, and of course, the C7 root. But because of anatomic variation, yes, we know that there could be that kind of prefaced brachial plexus where you can have contribution from, of course, C4. For this reason, about 5% of the population may have contribution from, of course, C4. And of course, even about 10% of the population, they may have contribution from, of course, C8. Okay, so all these variations do exist. Now, the important thing which I want you to become aware is that, yes, what could be, or what could happen, okay, which will result in this kind of injury to this nerve we are talking about. Yes, even merely, okay, by way of direct trauma to, of course, some of the ribs or even the fracture of what we call a rib or even the clavicle could cause an injury to it. Remember that I've told you that it's very long and it runs, downwards in that manner. Yes, not only that, even in situations where, of course, some kind of surgery, in situation of mastectomy, okay, removal of the breast, okay, is indicated, then care must be taken so that we don't cause injury to this, of course, nerve. Yes, not only that, even axillary, lymph node dissection, yes, it can predispose one, okay, to of course getting this nerve injured. Now, the important thing which I want you to become aware is that even sometimes, some viral, infections could cause, paralysis or not, could cause actually injury to of course this nerve. Okay, and viral infections, mainly something like influenza, okay, poliomyelitis virus, these things can of course cause some kind of injury to this nerve so that it fails to function, the right way that is supposed to, perform its work. My friends, one important which I want to make out over here clearly for you is that even by way of, we know that the brachial plexus will emerge from the, of course, the posterior triangle of the neck between, of course, the anterior neck, the middle, scalene muscles. Okay, then what happens is that in situations of scalenectomy, okay, if it's indicated, it could cause some kind of injury to of course this nerve. Now, enough of those things which can cause injury to this nerve. As far as this nerve is concerned, my friends, the fibers that it carries, they are only motor, and so if there will not be any sensory, okay, innervation to a skin or whatever, they will only give motor supply to, my friends, one muscle, one and only muscle. And so, my friends, what I want to tell you is that the sole muscle that is supplied by, of course, the long thoracic nerve is, my friends, the serratus anterior muscle, the muscle I mentioned initially. Now, this serratus anterior muscle, yes, oftentimes we also call it the box's muscle or the big swing muscle. Now, what's the reason? Now, this serratus anterior muscle, apart from keeping, yes, I'll be coming to that one, apart from keeping, the medial border of the scapula, okay, to or for the posterior aspect of the thoracic wall, my friends, it is also relevant in protraction of the scapula, Now, if someone wants to, a boxer wants to give a very big swing, okay, or whatever, do an overhead abduction to give a blow, then what happens is that we need the scapulae, okay, the two scapulae, for instance, to be abducted away from each other, or we need the scapula to be projected forward. Okay, so that is something that we call, protraction of the scapulae. So protraction of the scapula, where is relevant as far as boxing is concerned, yes, is by the kind case of the contraction of the fibers of serratus anterior muscle. Yes, so that is the important for which I want you to become aware of. Now, this serratus anterior muscle, as I told you, I said that it is also relevant in keeping the medial border of the scapula, yes, to, of course, the posterior aspect of the thoracic wall. And so whenever there is injury to the long thoracic nerve, then the fibers of the serratus anterior muscle will begin to waste. They become weak, and of course, they will not be able to perform the function of causing the scapula to be protracted. And so clinically, how do we test for this? And that's exactly the meeting for today's section. And so clinically, we test it by asking a patient to push, okay, using the upper limbs to push against a stationary object. So for instance, this wall, I'm going to push against it. So just observe what I'm going to do. So in pushing against this stationary wall, what happens is that if the serratus anterior muscle, okay, has become paralyzed, and for that matter, the long thoracic nerve is not really giving the sensation to it, then what happens is that as you push, for instance, if it's the right, serratus anterior muscle where it's paralyzed, and for that matter, the right long thoracic nerve where it's, of course, injured, then what we're going to see is that we will see that the medial border of the scapula, so as the patient pushes, the medial border of the scapula will become very prominent. And my friends, not only that, even the inferior angle of the scapula, so the medial border of the scapula, including the inferior angle of the scapula, will become prominent. And my friends, that is the clinical test, okay, that we employ in assessing the integrity of what we call the long thoracic nerve, and of course, the role of what we call the serratus anterior muscle. My friends, I believe you find this meeting helpful. And of course, you are going to share with friends. And of course, we are still in the era of anatomy of clinical importance, all the clinical bits that you need to be aware of. This is the season. Okay, so tell a friend to tell another friend to, of course, enjoy all these meetings. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.